Hello everyone, welcome back to our NCLEX Review. And for those who just joined us today, we are on the 5th day of the 90-day free NCLEX Review classes, which we schedule daily 12 p.m. Eastern Standard Time. And so we'll be covering all the nursing subjects and also rationalization of about 2,000 NCLEX-style questions. But for today, I'll talk about the nursing care and management for an adult patient with nephrotic syndrome, and we'll have some Q&A right after. So to get started here, we need to really identify what this disorder, especially in the adult. And so here, we're talking about nephrotic syndrome in the medical surgical level. And so this is a condition that is characterized by a significant increase in the urine protein and also a low blood albumin known as hypoalbuminemia and swelling or edema, and also some elevation of the blood lipids. And these are the symptoms that will arise due to the excessive plasma protein leakage into the urine. And this can result from the increased permeability of the glomerular capillary membrane. So these are the hallmark signs of nephrotic syndrome. And so first one is we have the proteinuria, which is going to be about 3 grams per day. That's a lot of protein leaking into the urine. And then we're going to have the hypoalbuminemia, which is decreased serum level of the albumin. And then we have edema. Hyperlipidemia, which is an elevation of the LDL and also the triglycerides. We also have infections and possibly thrombosis. So I really want you to focus on these manifestations because these are the often asked situations or assessment findings in the nephrotic syndrome. Now, at this point, we're going to talk about the pathophysiology and the different causes and also some conditions that can lead into the nephrotic syndrome. So I really want you to pay attention and want you to follow all the way. Now, we are going to talk about the different contributing factors such as the diabetes mellitus, which is the leading cause to nephrotic syndrome. And of course, this can result into what we call as diabetic nephropathy. Now, let us refamiliarize that with consistent high blood sugar levels can damage the blood vessels in the kidneys, including the glomeruli, which can increase the permeability and also protein loss. Now, another condition that is associated with nephrotic syndrome is amyloidosis, and this is a condition wherein there is an abnormal protein deposits called amyloid buildup in the organs and also the tissues, including the kidneys. Now, when this happens, when there is amyloid deposits in the glomeruli, it will disrupt the normal function and also the integrity. That's why it can also cause leaking of the protein into the urine. Now, yesterday we talked about the SLE, which is one of the triggering factors in glomerulonephritis. Well, SLE is back to cause some problems, especially in nephrotic syndrome. And we know that this is an autoimmune disease where it will attack its own tissues, including the kidneys. Now, there will be immune complexes that will be formed by the antibodies and also the antigens deposited in the glomeruli. And so this will also cause the inflammation and damage that can result in the nephrotic syndrome. Now, we also have the viral infections such as the hepatitis B rather, and also hepatitis C and HIV. So these viruses can directly infect the kidney cells, or it might cause an immune response that can damage the glomeruli. So for instance, we have hepatitis B and C. They can lead to membranous nephropathy, while HIV can cause HIV-associated nephropathy. Now, we also have a medication here which is often quoted, the non-steroidal anti-inflammatory drugs that can cause a direct toxicity to the kidney cells, and it can also lead to a condition called minimal change disease or membranous nephropathy, and both of which can cause nephrotic syndrome. Now we also have some immune complexes, deposition in the glomerulus, which is basically the same mechanisms that we knew about yesterday with the glomerulonephritis. So it's going to be the same pattern wherein the immune complexes from the various autoimmune diseases, or let's say chronic type of infections, can also lodge into the glomeruli, and it will also cause inflammation and damage. Now, there's also the deposition of the immunoglobulins in the glomerulus, and again, such as the deposition of the immunoglobulin A, it can cause nephropathy also, which can directly affect the glomerular function. And so the same pattern, it can also trigger the inflammation of the glomerulus and some subsequent damage to the nephron. Now, all these factors that I had mentioned can do the same end effect. It will definitely damage the glomerular basement membrane. Again, we're talking about the GBM. That is the middle layer of the glomerulus, right? And so when this is going to be compromised, when it becomes more permeable, it can now allow the proteins that should stay in the blood to pass into the urine. Now, again, this is going to cause the damage into the structure, the GBM. Now, this will also include the leaking of the critical proteins, okay? And so we know that the moderate and also the large size molecule of proteins will be leaking into the urine. So remember those groups that I've mentioned? I want you to recall, because they're going to be the same kind of proteins that will be leaking into the urine. And so let's talk about the first group of proteins that will be leaking, and this is the antithrombin, also the protein C and the protein S. Okay, so these substances are actually innate anticoagulants inside the body. So they will kind of buffer into the procoagulants to prevent inadvertent coagulation throughout the body. And so if the body will run out of these three substances, then the person will be at a higher risk to develop thrombosis. Okay? And so again, these are our natural anticoagulants in the body. And so when they are going to be depleted inside the body, well, what do you expect? There will be thrombosis, and it can affect several areas in the body, and one of the primary site is the renal vein, and it can cause problem. It can lead into an impairment of blood supply to the kidney. Now, it can also lead to pulmonary embolism, because it can involve all the blood vessels inside the body, all the circulating blood. It can have a tendency to clot. And so the person here will be at higher risk to develop pulmonary embolism, and it can also travel into the other systems of the body. Maybe the brain, maybe a TIA can occur, or maybe a stroke. Or in some cases, with the sluggish circulation, there will be now some form of hypertension that will develop because of that hypercoagulable state. And this is something that we need to pay attention, because this person can really go into these complications really fast. Now, another protein that we wasted into the urine is the, or another complication here is the synthesis of the lipoproteins. And this is because of the rapid loss of the proteins in the urine. Then the body will try to pause this process. That will lead into hyperlipidemia. And so there will be now an increasing circulating volume of triglycerides. HDL, or the LDL rather, will be elevating. And for those patients that have been having recurrence of the nephrotic syndrome, then they're going to end up with some atherosclerotic disease later on. Now, another protein that we're going to be worried about is the albumin, which is basically the major protein in the blood that is going to maintain the oncotic pressure. Now, again, oncotic pressure is exerted by the albumin, right? So I had I mentioned about that yesterday regarding its role to act like a sponge. So it will prevent the vascular fluid to leak into the interstitial spaces. And so it has that sponge effect. However, this time, because of the body running out of the albumin, then what's going to happen here? There will be a decrease in the oncotic pressure. Okay, so it will lose its sponge effect. And what's going to happen here? There will be generalized edema. The person will have what we call as anasarca, and in turn, this will activate the RAS system. This is the renin-angiotensin-aldosterone. Okay, so I want you to recall the lecture I gave you on the first day of the renal concepts. So again, this will be activated because of the loss of fluid into the urine. Now, when this is activated, it can lead into sodium retention, and so the person here will end up with hypernatremia, of course, and some other major problems later on, which we will be talking later. Now, please pay attention here, because not just the albumin is affected, and not just the protein C or the antithrombin, but we also need to be worried about the immunoglobulins. These are your moderate-sized particles or molecules, and they're also going to leak into the urine. So these are your immunoglobulins, IgG and the IgA. And we know that these are vital in the immune system, right? They are going to responsible to fight off infections. And of course, when there is a deficient presence of these immunoglobulins, then the body's ability to defend against pathogen will be greatly diminished. Now, what we're going to expect here is that there will be some infections that can occur to our patient, and most of these infections will be could be a gram-neg or gram-positive, like your E. coli or Pseudomonas aeruginosa, or it could be the Neisseria gonorrhoeae, or it could be the Staphylococcus aureus or MRSA, or Streptococcus pyogenes, or it could be a Streptococcus pneumoniae. And for some people, they are going to be really prone to catch some chickenpox or varicella type of infections. Now, I really want to recap this so that you can retain this in your subconscious. And so with the nephrotic syndrome, this process will start with the different conditions that can cause damage into the glomerular basement membrane. And so it will cause the basement membrane into more permeable, okay? And so it will allow the proteins to leak out, and also the essential anticoagulants like the protein C, S, and also the antithrombin, and also the immunoglobulins. And so these loss of the important proteins will really going to cause some major complications, like the blood clots that I mentioned, also the kidney damage, and pulmonary embolism, stroke, hypertension, edema, and also other risks of infections. Now, I hope that you're able to capture that, because the way we're going to base our assessment findings and also our laboratory testing and also our nursing care and management with this diagram. Now, we're going to talk about the different diagnostic tools or tests that will be ordered by our medical provider. And so first things foremost, the most popular sample that we will be expecting is the urine sample for urinalysis. Now, when the person has the nephrotic syndrome, what you're going to expect here is that there will be proteinuria. That is the hallmark of nephrotic syndrome. There is massive leak of protein into the urine. Okay? Now, this is going to be the first classic manifestation. And so don't get confused. We will make this much easier. And so another testing that you will be expecting, or another significant finding that you will see with the urinalysis, is the presence of the blood, especially the microscopic red blood cells, right? And so some of these red blood cells can actually leak into the urine, and some casts, or the urinary cast, which are actually tube-like particles, they are like white blood cells, red blood cells, or kidney cells. They're going to form in the kidney tubules, and their presence can indicate kidney disease. So when you're going to look into the laboratory data of your patient, irregardless if they are with cardiac problems or maybe other urinary disorders, you're going to get started to worry about the urine result if there is some urinary cast. That's going to worth some form of kind of investigation. Now, another here is the foamy appearance. I mentioned about this yesterday, that foamy appearance in the urine actually will signify that there is a whole lot of protein in the urine. It will appear like a beer. It becomes bubbly. And even though it's not really a definitive test, it is gonna give you a clue that something is very off with the kidney function. So I want you to recall all these findings in the urinalysis. This will really guide you in the care of your patient. Now let's move on into another testing here, which is the 24-hour urine collection, which is something that I've done way too many times. And even I've collected like the 48-hour urine collection. I get lucky sometimes that when I come back for the 2 days, I'm still able to collect those urine specimens and send them to the laboratory. But here, we're only talking about the 24-hour urine collection. And of course, the same thing is going to happen here. We will see increased protein. There's proteinuria. Again, there is about 3.5 grams of protein lost in the urine every day. Imagine that. And with this, it will actually also reveal a potentially decreased creatinine clearance. Now, this is actually going to help us tell that the kidneys are not able to really filter the waste products. And so the creatinine clearance that we'll be expecting here will probably be decreased. Okay? Now, another is the urine protein electrophoresis. So this is going to analyze the different proteins in the urine. So this is going to separate the proteins in order to identify their types, and it will also help pinpoint the specific proteins being lost. And this can also give us some clues about the underlying cause of the nephrotic syndrome. Okay, so here we'll be able to tell if it's the moderate size or it could be the large size protein molecules. All right. Now, moving into another testing here, which is the definitive diagnostic test, the kidney biopsy. And so this is going to be the procedure that will involve histological exam. So this will this involves the collection of a small tissue sample, and this will confirm the diagnosis. So here, the test will reveal the type and also the extent of the damage to the glomeruli. And so this will help our medical provider to determine the specific cause and also the best treatment plan that they will incorporate in the patient's care. Now, another testing that we are going to expect are the blood tests. And so here we're going to expect low total protein. And I just give you here the normal range, which is actually 6 to 8.3 grams per deciliter. So anything below 6, that's already considered as low protein level. All right, because there's another testing for the albumin. Now, with the albumin, anything that is below 3.5 grams per deciliter is already considered hypoalbuminemia. Okay, And so if I'm talking about total protein, it involves all the different kinds of proteins in the body that will be possibly leaked out into the urine, right? But we're going to focus also in the albumin, because this is the main protein that is responsible in the oncotic pressure. It will hold the fluids inside the body, supposedly. Now, here at this point, we are going to talk about the creatinine level, which is going to be elevated as well. And this is going to suggest that there is impaired kidney function, and this is commonly going to be found in a more advanced stage of nephrotic syndrome. Okay? Again, this is going to be much more elevated during the advanced stages of nephrotic syndrome. Now, another test that we'll be expecting to see as being elevated is the triglyceride. Okay, remember that because of the massive wasting of the protein, the body will try to produce more of the lipids. And so this can also cause the problem. This is going to elevate the triglycerides and also the cholesterol levels in the bloodstream, and this will place the patient into different cardiovascular activation. Remember that there is reabsorption of the sodium ions by the kidneys. It will allow those sodium ions back into the circulation. Now, at this point, we're going to talk about the possible complications of the nephrotic syndrome. So one of those is the hypovolemia. Since we are going to lose the proteins, also we are going to lose the circulating fluid inside of the vascular compartment. It will be depleted, right? And so the patient will be at risk to develop dehydration. That is one, okay? And another is the thromboembolic events. And this is going to affect the renal vein. It can occlude the renal vein and also can possibly cause pulmonary embolism and hypertension, could be stroke. All right? So because again, we are losing the natural anticoagulant inside the body, which are the protein C, the protein S, and the antithrombin. Now, another thing that we're going to have to expect here, since we are losing a lot of the albumin, okay? And I've talked about the albumin's role, especially with how it's going to deal with the different medications. And so when we are going to take care of a patient, and some of these patients are taking meds that are possibly highly protein bound, and so that simply means that these medications are considered to be toxic when the person's body has a deficiency in the amount of the albumin. So I'll explain this one much clearer, so you'll be able to capture this one. So this is basic in pharmacology, wherein the medications being taken, this is going to be available in the bloodstream, right? And for some medications, let's say the moderately high or highly protein-bound drugs, let's say, for example, anticonvulsants, let's say non-steroidal anti-inflammatory medications, warfarin or Coumadin, these are known to be highly protein-bound. And so the implication here is that they are supposed to attach into the albumin, okay? So it's not that when you have ingested a highly protein-bound drug, that when you ingest it, when it's available to the bloodstream, that it should readily go into the tissues. No. When we're talking about highly protein-bound drug, they're supposed to attach into those albumin. And then one by one, they're going to have to detach. So the circles here, okay? These are your albumin molecules, right? So the medications, those highly protein-bound medications, will attach into the albumin, supposedly. And once those particles of medications have already been used up, when they have gone into the different body tissues, then slowly some of those medication particles will detach from the albumin, and they're going to go directly into the tissues. So slowly they're going to detach up until the medications will be no longer available in the system. So that's how what a highly protein-bound medication behaves inside the bloodstream. Again, if there is a low albumin in the system, so what do you think? There will be no attachment for those free drug, right? So they're going to look everywhere. There's no more albumin. So what's going to happen? These medications will go directly into the body tissues, those receptors, causing rapid drug action. And some of these medications are really not supposed to do that. They're supposed to just slowly detach in a normal mechanism, right? But here, it will directly cause that rapid effect. And so this is going to cause some toxicity into the patient if they have hypoalbuminemia. Okay, so I hope that you're able to catch that. So again, if there is low albumin in the system, it will cause an elevation of the free drugs, especially the highly protein-bound drugs. Free drugs, it's not good, all right? Now, we're going to talk about some infections. So what are these infections that can potentially happen? Well, I've mentioned those, the positive or gram-negative or gram-pos bacteria, could be viruses, or it could be, yes, the chicken pox. So those are potential infectious microorganisms, can become opportunistic when the person has been depleted of the immunoglobulins G and A. All right? So here, I want you to recall really the importance of the immunoglobulins here. So for the immunoglobulin G, or actually A, this is the predominant antibody that you can find or known to be found in the mucosal surfaces like the GI tract or the gastrointestinal tract or the urogenital tract. And so they're all going to be found in the saliva, the tears, and also the breast milk. And so the IgA can also play a crucial role in actually protecting the mucosal surfaces from any kind of infection, because they are supposed to neutralize the pathogens and will prevent their attachment and also the invasion of these pathogenic microorganisms. And so their role really is to bind to the pathogens and also the toxins, and they're going to neutralize them before they can enter the body tissues. And we know that their pathogenicity is actually going to be diminished because of the action of the IgA. Now for the IgG, the immunoglobulin G, these are the most abundant immunoglobulins in the blood and also the extracellular fluid. And so, as we know, like, this is the only antibody that can also cross the placenta, and this will provide some passive immunity into the fetus. Now, recall now that the IgG, the role for this type of immunoglobulin is actually to do the opsonization. I hope that you still remember that, wherein the antibodies will coat the pathogens. They're going to mark them for destruction by phagocytes. And so they're going to mark those microorganisms in order that the body, those phagocytes, can easily ingest them. All right? And so they are also responsible in neutralizing those toxins and also the pathogens. They're going to attach to them. They're going to block their ability to infect other cells and also interacting with host tissues. Now, the role of the IgG is to also activate the complement system, wherein it will cause a series of the proteins that will assist in destroying the bacteria. Remember about the C3 that I mentioned yesterday with the glomerulonephritis? The complement 3 is actually one of those important aspects in the complement system. And so here, the complement, the IgG actually gonna activate that as well in order to prevent the formation and also to actually activate, that will lead the formation of a membrane attack complex. And so with the absence or diminished amount of the immunoglobulins A and G, so what do you expect? Well, the person is really going to be prone to developing so many infections. And especially if they're going to be in the hospital, they can easily get those healthcare acquired infection, okay, or nosocomial infections because of their suppressed immune system. Now, at this point, we're going to talk about the different management of the nephrotic syndrome. And here, we're going to talk about the different pharmacological items. So part of that would be the administration of the diuretic. So the diuretic that I am talking about here would be the loop diuretic, which is the furosemide. And this is going to be ordered to decrease or to actually allow excretion of the excess fluids. As we know that the body has edema, right, from all these interstitial spaces, then we're going to have to make sure these are going to be excreted, okay? And another medication that we're going to expect to be part of the treatment is the ACE inhibitors. So this is the angiotensin converting enzyme inhibitors. So I hope that you're still familiar with this medication classification. And this is an antihypertensive drug. And what it does actually is to prevent vasoconstriction. That is one. Another is it will prevent the release of the aldosterone, because there is no conversion from angiotensin 1 to angiotensin 2. So there is no triggering effect into the adrenal cortex to release the aldosterone. It doesn't happen because there is no conversion at all. And so what you're going to expect here is that there will be no reabsorption of sodium ions in the kidney tubules. There's also no reabsorption of the water in the kidney tubules. So that's on top of its vasodilatory effect. It will be beneficial for the patient to take this medication because the ACE inhibitor can actually help widen the afferent arterioles. Remember, this is one of those blood vessels that will actually lead the blood to go into the glomerulus. So the afferent arteriole diameter will be widened. And so when this happens, when the diameter is bigger, it will allow a very much slower or lower pressure. Okay, so when there is a low pressure inside that blood vessel, the hydrostatic pressure will also go down. So simply, it will decrease the chances of allowing those proteins to leak out from the glomerulus into the urine because of the lower pressure inside the glomerulus, or glomeruli, I should say. So that is the therapeutic effect of the ACE inhibitor. Again, it will widen the afferent arterioles and also to decrease the hydrostatic pressure, and thereby it will decrease the forced leaking of the proteins into the urine. All right. Now, I also need you to get familiarized with another classification, which is the corticosteroids. They're actually considered as immunosuppressants as well. And so this is what we referred way back in the past as the wonder drug in the treatment of nephrotic syndrome. And this just started to be popularly used way back in the early 90s or 2000. And so we really refer this medication as the wonder drug because it will decrease the inflammatory process, especially with the blood vessel, especially the blood vessel in the kidneys. And so it will decrease the inflammation of the glomeruli, and it will also decrease the incidence of proteinuria. Okay? Now, another medications that we have are the anticoagulants. Why are we giving anticoagulants to the patient with nephrotic syndrome? Well, this is going to be based upon the lab work of the patient, their coagulation studies. If there is, let's say, increasing clotting time, then there is a high chance that the patient will have some coagulopathy, or let's say they're going to be prone to developing blood clots easily. All right, and so the anticoagulants that we're talking about here, it could be in the form of an injectable heparin, the infractionated heparin that we can give as a subcutaneous. It could vary in different doses as well, or it could be in a form of warfarin or Coumadin, or it could be the novel anticoagulant medications. All right, and so these medications will actually prevent the formation of the blood clots and to prevent those thrombotic complications. Because again, we are talking about a possibility of PE, a possibility of a stroke, a deep vein thrombosis, and also the renal vein thrombosis. That's why we are going to anticipate administering this medication. And so if the patient probably would be complaining of, let's say, a flank pain, well, that is not a good assessment finding. If the person will be complaining of the flank pain and they have an established diagnosis of nephrotic syndrome, this is not going to be about pyelonephritis, because pyelonephritis is a totally different entity. And so here, with a patient that has nephrotic syndrome, it's not about the infection, but actually it's the thrombosis of the renal vein. And so this is a medical emergency that needs to be dealt with. Okay. Now, another medication that we'll be expecting, or another treatment that we'll be expecting to be implemented, will be the edema management, and we can do this by simple application of compression like TED hose, or also leg elevation, maybe sodium and fluid restriction. So these are preliminary management for the edema. One is the infusion of albumin, which is a blood product, and this is going to be administered just similar to a blood transfusion, but albumin is that yellowish, clear yellow fluid that we give to patients, especially in renal disease, for those who have ascites, for those people that may have some hypotension issues. And so this is really going to help out in this patient with a nephrotic syndrome. It will prevent the further leaking of the fluids into the interstitial spaces, and also will decrease the incidence of edema. Okay, so remember, albumin infusion. Okay, so this is something that we're going to expect to administer. Okay, so this is not really like a blood product per se, like similar to a platelet or let's say a red blood cell. No, it comes in a bottle that we administer with the regular IV tubing, and can be done through a regular IV pump. All right, but you really need to pay attention as well, because some of these patients can develop some adverse reactions with the albumin infusion. Right, now we're going to talk about some dietary protein supplements, and this is very important that we're going to involve the nutritionist or the dietitian in the care of the patient, because when they are losing a lot of those proteins, the immunoglobulins, the albumin, those proteins that are involved with the coagulation, when these are lost, remember all these complications that we just talked about, we need to replenish these. Okay, and so we're going to involve the dietitian or the nutritionist in order to boost also the immune function. Remember about the IgG, IgA. And we're going to have to reverse this effect by allowing a much more solid nutritional treatment to our patients. So what we're going to promote here is to allow them to take supplements containing the vitamins and also the minerals that will also improve their immune function. It could be in the form of a vitamin C, vitamin D, it could be zinc. That will help reduce the risk of infections. Now, also we're going to have to anticipate about some dietary adjustments. So one of these would be to reduce the intake of saturated fats. Oh boy. Reduce the intake of saturated fat. Well, because there is hyperlipidemia, hypertriglyceridemia, because of that liver causing the synthesis of more lipids, because it's sensing that, hey, the body is getting malnourished right now because we are not getting the protein. So it's forced to convert, causing this complication. And so what we're going to do here, we are going to control the hyperlipidemia or dyslipidemia by, of course, with a dietary modification, but we also have to anticipate the administration of the statins. And these are the first line medications that will help manage hyperlipidemia in nephrotic syndrome. So what they're going to do is actually inhibit the enzyme that is involved in the cholesterol synthesis of the liver, and they are going to lower the low density lipoproteins, which are what we refer as the bad cholesterol level. And so this will really reduce the risk of the cardiovascular events. And I hope that you still remember the medication names here. We have the statins, right? So you have the atorvastatin, simvastatin, rosuvastatin, pravastatin. So there you go. Those are the generic names of these statins. Now, another is the acetaminophen, which is another medication that can be ordered or that can be part of the prescription in combination with the statins to further lower the low-density lipoproteins. And this medication acts by blocking the absorption of the cholesterol from the intestine. And this will lead into a decrease in the levels of the LDL in the blood. So how fancy is that? But I recall taking this medication way back about probably 10 years ago. And so I actually took like 5 doses, daily doses. And about a week later on, I started to feel like having flu-like manifestations. My muscles were like kind of achy. So I thought that I had some kind of influenza. But when I review the adverse effect, that's actually the adverse reaction. So immediately the medication was discontinued, and that was replaced, because this is one of the adverse reaction of like this kind of medication. So another is the fibrates. And so this is another class of medications that will target the triglyceride in the blood, but they can also elevate the HDL, right? The good cholesterol. And so they are going to be prescribed in combinations with the statins, especially for those patients that have persistent hypertriglyceridemia, despite they've been on the statin for so many months already. And so the fibrates is represented by the gemfibrocil, or known as the fenofibrate. Now, another group of medications that we'll be expecting here to administer will be the bile acid sequestrants. And so these are, this is a classification represented by the cholecalciferol, which is going to be given orally. And this is to bind the bile acids in the intestine. And so it will prevent the absorption, the reabsorption. And so what is expected here is that there will be increased excretion of the bile acids and also the cholesterol. So what is the expectation here? There will be now a decrease in the LDL. When you're going to look into the labs, it will surprise you. Now lastly, we have the omega-3 fatty acids, which is considered as a supplement, and they're going to contain the eicosapentaenoic acid, and they're really known to be very beneficial, especially on the lipid profile. So they're gonna really reduce the triglyceride levels, and yeah, this is very beneficial. You will see a whole lot of your patients taking the omega-3. Most of the adult patients that you'll be taking care of, they're gonna probably see this in their medication list. Now, we're going to talk about the possible, actually we're going to talk about the nursing care at this point. So what are those key nursing actions that we need to implement into this patient? Well, when we are taking care of a patient, especially if this is the first time that you've met the patient, you are the ones admitting the patient, then definitely you need to get thorough symptom and history taking. That is very important, because if you're not going to be able to dig deeper into their medical history, and also if you're not obtaining the most important data, especially the medications that they're taking, the important past and present medical history, you're really going to miss those important information that could delay the treatment. And so what we're going to do here is to document the different symptoms, maybe the onset of the symptoms, if there's any urinary type of changes, the onset of the swelling. And so these are the key findings that we need to find out. Okay. Now we're also going to do much thorough physical exam. So again, since we're going to expect this patient to have fluid shifting from the vascular compartment into the tissues, well, edema is very obvious, right? So you really need to pay attention into the overall body parts here. You gotta check into the dependent areas of the body, the legs, and also ask the patient if they have noticed any form of swelling in the sacral area. So you probably would really need to take a view of the private areas as well. And also, well, some of these body areas that are known to swell up easily, of course, the hands, the tissue surrounding the eye, or the sacral area, or the legs, or the feet, they can easily be detected. But I really want you to pay close attention to other areas of the body when there is edema. Now, what we're going to do here is to properly do our assessment. Well, of course, vital signs is very important. We're going to have that baseline information in order for us to compare future readings, and also make sure that we are checking for the edema and their status, such as hypovolemia. They're running out of the fluids, right? And we gotta check their weight, baseline information of their weight on admission, and then we're gonna have to daily monitor their weight as well. Now, intake and output measurement is a biggie here. Anything that involves fluid and electrolyte imbalances, weighing, intake and output measurement, edema checking, vital signs checking, these are basic. You should not forget these skills in your assessment. Now, another thing that you need to do is to check on the laboratory studies, compare it with the previous laboratory results the patient might have. And so you really need to pay attention into the trend of the renal function studies, the albumin level, to see if these are significantly decreasing, or maybe the creatinine level is now skyrocketing. That is not a good sign, because the patient now is probably going into renal failure. Now, another thing that we need to do here, especially in the implementation phase, we're going to have to monitor the daily weight strictly, and intake and output measurement will be done strictly as well. Any significant variations need to be reported to the medical provider, and make sure that we are checking the urine specific gravity to see if there is major changes, and also the vital sign, checking the creatinine, the BUN, and also expect the administration of the medication that we tackled earlier. So one of that would be the diuretics, could be the albumin, to prevent further wasting of the fluids, and also we want to make sure that the edema is lessened. Now, it's very important that we're going to prevent the infection, since we are losing way too much of those immunoglobulins, and we are going to check the patient for any manifestations of infection. I know that you have mastered this probably, because we have repeated this so several times. Signs of infection, fever, tachycardia, could be change in the color of the drainage, urine, some sort. And so you really need to pay attention to those. And checking onto the white blood cell count with a differential count, look into the levels. Let's see if there's any leukocytosis. All right. Now, when we are performing some kind of invasive procedures to the patient, let's say there's an order for us to place a continuous, what do you call this? A Foley catheter. That's very simple, right? You really need to do this strict surgical asepsis, aseptic technique, in order for us to prevent occurrence of urinary tract infection. Or let's say if you are putting in a new IV, or let's say you're changing the central line dressing, you need to observe aseptic technique when you're removing the old dressing and also when you are applying the new dressing. This is something that you need to do in order to prevent those opportunistic infections from coming into their system. Now, what we're going to do here is to really encourage the patient to participate, especially when we are teaching them together with their family, with their spouse. It is very important that we are going to impart the necessary information in order that the patient will comply to the treatment regimen. Okay? And so one of those teaching pieces would be the symptom awareness. And this is about teaching the patient on the different syndromes or manifestations that they might experience at home. And so this is what you need to do. Make sure that you're going to describe this to the patient and the family member, these following symptoms, in order that they can report all these findings to the medical provider. Now, another is teaching them about the different medication side effects. Okay? And so again, if we are talking about the administration of the steroid, glucocorticoid, remember that it can cause hyperglycemia, it can cause weight gain, sodium retention, and also the patient may be prone to developing more infection. How sad is that? The patient already has nephrotic syndrome and they're prone to getting opportunistic infection, and they're going to be treated with corticosteroid, which will further cause immune suppression. So we're actually, that's going to be a problem as well. And so we want to make sure that we are teaching our patient to not expose themselves into crowded areas as much as possible, and make sure that they know in practicing strict hand hygiene, and if unavoidable, if they really need to show up for the doctor's appointment, they need to wear their mask because they're really going to be prone to catch those opportunistic infections. Now, another is diet and fluid management. And we talked about the different dietary modifications. And so, again, we are going to involve the nutritionist or the dietitian into planning their meals. Okay? Now, there's also going to be a need for lifestyle changes. And so we are going to incorporate maintenance of exercise, reducing the cholesterol, also the fat intake. Especially everything is so much like patients can get their fast food so easily. And so very easy to access. And so, yeah, there's going to be a need to modify their lifestyle. And so a reduction in the intake of those cholesterol, fat, fatty food items, and we need to address those other risk factors like smoking, obesity, and also to address stress in order to lower the risk of thromboembolic events. Now, another thing that we need to do is to prepare the patient for severe disease development. And because if they're not going to respond to the therapy, if they have been non-compliant to the treatment, they're not taking their corticosteroids, they're probably not taking any of the antihypertensive medications or the anti-lipemic medications, or the supplements, then this will cause a much more worse of a problem here. So they might go into a renal failure, or it could be the end-stage renal disease. And some of these patients will really going to go into the end-stage renal disease if they are not compliant, if they are not showing up into the appointments with the doctor, and so when they come back, their kidneys are already shut down. So this is something that you really need to emphasize in educating your patient. Now, we're going to have a quick break here. And so again, we are promoting our special offer to you, especially for your friends that are not aware yet that we are conducting the free classes for the 9 days period. So today, this is the 5th day, right? And so I really want you to invite your friends to see the videos that we have recorded for the live sessions. I want you to encourage them to attend in the live sessions as well, so they'll be able to get refreshed. And we also want you to grab the opportunity, especially with the offer for our website at www.stancoast.nclexcoaching.com. We do have different offers here, and I want you to check into the description below for more details. Now, let's go into the different questions that we will be answering here. And so here's the first question for you. So it says here, the nurse will expect to educate a nephrotic syndrome patient who experiences flank pain regarding treatment with. Again, the nurse will expect to educate a nephrotic syndrome patient who experiences pain or flank pain regarding treatment with A, is it medications for bacterial infections, or is it B, medications for fungal infections, or is it C, blood thinners, or is it D, medications for high blood pressure? I want you to take your pick right now. Is it A, is it B, C, or D? All right, time is up. I hope that you were able to formulate your answer here. And so the scenario is showing us a person or the nurse educating, will expect to educate a nephrotic syndrome patient who experiences flank pain. So our scenario here will revolve into the manifestation of this patient with a flank pain. Okay? And I just mentioned this just not too long ago about the flank pain in a patient with nephrotic syndrome. So what do you think is the answer? Is it A, medications for bacterial infection? Is it indicated for that patient? Well, let's take a look. Well, for this patient with the nephrotic syndrome, and if they are having flank pain, actually, this is not going to be really the answer, because the antibiotics are only going to be indicated to those instances wherein there is a real infection, in the case of pyelonephritis, right? And so at this point, the medications, or let's say anti-infectives, antibiotics, will not do any good to the patient, because we are not thinking about the urinary tract infection, not at all. So we're going to eliminate that easy peasy. What about letter B, medications for fungal infections? Is the patient with the nephrotic syndrome in this scenario with a fungal infection? And we did not talk about fungal infections at all with the discussion of our pathophysiology. We did not mention about that. And so this is something that can only occur in a patient with pyelonephritis, with the fungal type. So we are going to eliminate this one. And then what about letter C, blood thinners? We call them as blood thinners, referring to the anticoagulants like your oral, warfarin or Coumadin, heparin, or the NOAC. This is going to be indicated for this patient, especially that we are thinking that the patient probably has renal venous thrombosis, right? It is a medical emergency. this is something that we need to treat right away in order to prevent the enlargement of the clot. We need to do the anticoagulation as early as possible for this patient. And also to prevent other complications like PE, right? Or renal failure. Now, let's take a look into letter D, which is medications for high blood pressure. Well, the patient here with the nephrotic syndrome is actually going to be not going to need about the antihypertensive, right? There will be hypotension in this patient. So we're going to eliminate this choice as well. So for the test-taking skills that you need to do here, what we're going to need is to simply understand the medical condition being talked about in the question. And so again, we are revolving our scenario on the flank pain on the patient with the nephrotic syndrome. And we need to analyze here the symptom associated. Now, remember, we need to match the symptoms according to the described scenario, and also look for that question stem and make sure that we're going to direct with the proper treatment option. Now, another is we're going to have to also consider the prevalence. We want to recognize the rarity of the fungal pyelonephritis compared to the other causes of flank pain, and also to choose the treatment accordingly. But like I've said, again, these manifestations do not reflect the assessment findings in nephrotic syndrome. All right. Now, let's move on into the next question here. It says a 48-year-old female patient is hospitalized due to the sudden onset of nephrotic syndrome. What clinical signs would the nurse anticipate assessing? So we have an adult patient, female patient, with a sudden onset of nephrotic syndrome. So what clinical signs would the nurse anticipate assessing? Is it A, diminished skin elasticity? Or is it B, recent increase in body weight? Or C, presence of ketones in the urine? Or is it D, reduction in the blood pressure? I want you to take your pick right now. All right, let's move on. Now, our scenario here is about, again, a patient with a new sudden onset of nephrotic syndrome. So what are these clinical findings that you are going to expect? Well, let's go through each option here. Is it A, diminished skin elasticity? Remember, guys, that our patient has edema, right? There is presence of fluids into the interstitial spaces. There will be puffiness of the skin. And so the elasticity of the skin is not diminished at this point, okay? There is no loss of elasticity because of the edema. Easy peasy, eliminate that one right away. What about B? Recent increase in body weight. Well, yeah, nephrotic syndrome. Remember, there is increase in the body weight, and because of the shifting of the fluids from the vascular compartment into the interstitial spaces, all right? The body is not really enjoying the fluid, because when I'm saying enjoying, it should be circulating in the bloodstream, right? But what's happening here is that the fluids are in the interstitial spaces. They're not usable. They're just gonna sit there, nothing else. And they can put the patient at risk to developing skin breakdowns, right? Puffy skin tissue or puffy tissues is never good for a patient, especially if they're debilitated. And so back to here, recent increase in the body weight. This is very significant, and this is one of the key assessment findings that we will be noticing right away. And so again, the reason that there is a sudden weight gain is because of the increased permeability of the glomerular filtration barrier, which actually will cause the proteins to leak into the urine, and this is going to cause the hypoalbuminemia, and then what's going to happen? This will lead into the fluid retention into the interstitial spaces. Okay? Remember that we lost that sponge effect because we are running out of the albumin. And so again, those body fluids will leak into the interstitial spaces. So that's not a very usable form of fluid. Now, another here is, so this is going to be a possible correct answer, and then we're going to check on option letter C, and this is presence of ketones in urine. Well, I did not talk about ketones regarding our case today, which is nephrotic syndrome. It's never. You will never find ketones in the urine if the patient doesn't have a DKA. And so this is not a classic or a hallmark in the nephrotic syndrome. Okay, so we are going to eliminate this one easy. Okay, no ketones in the urine. Now, letter D, reduction in the blood pressure. Remember here, what clinical signs would the nurse anticipate assessing? Remember, guys, that there was an activation of the RAS, the renin-angiotensin-aldosterone system, and this is going to cause a reabsorption of the sodium ions, and this is going to cause the blood pressure to go up. And so hypertension is a common manifestation at this point. So don't forget about the RAS this time. Now, for the test taking skills, so we have our answer here, letter B. Let's circle that. The rest, they're erroneous. So for the test taking skills here, what I want you to focus here is to understand the pathophysiology of the nephrotic syndrome. And so if you're really solid into understanding, not just about mnemonics, because I've tried this way back in the past. I've tried cramming, studying in nursing tests when I was back in college. I tried to cram my brain with all those mnemonics. It just doesn't work for me. As soon as I forget that one letter, everything will be lost. So lucky you if you're going to be able to memorize these mnemonics, but for me, it just doesn't work. And so that's why I really need to go deeper into the pathophysiology so I can understand better and so I can generate those nursing processes because I'm understanding the disease process pretty well. And so I would really recommend that you do that as well instead of just memorizing the mnemonics, because if you're just going to rely on the letters, mnemonics, this is some kind of like a short-term kind of assistance. And so most of the time this will be lost when you're going to gain some more information. And that is really proven that some of these will be easily forgotten. So I really want you to go back into the concept and really understand the disease process. All right. Now, another thing that we need to understand, part of the test taking strategy here, is to recognize common clinical manifestations. And again, we're going to look for the hallmark signs, those symptoms that is associated with the nephrotic syndrome, and also we are talking about the weight gain, right? And so again, this is something that you would really associate with this diagnosis, okay? This will also narrow down your options. Now, again, you are going to employ the use of the process of elimination. You have to rule out those incorrect options, like the skin turgor, elevated ketones, based on the pathophysiology, okay? So, like I've said, always do it by the elimination process. Look for those incorrect answers, all right? You have to do some kind of a self-debate. Is this present in this disorder? Is this not? So you have to think over and make sure that you go through that elimination process before you look for that answer, okay? Now, that is it. We're going to move on to the next question. Question number 3. The nurse is tending to a 28-year-old patient with acute inflammation of the glomeruli, which is basically glomerulonephritis. What symptoms would the nurse anticipate in this client? Select all that apply. 28-year-old patient with acute inflammation of the glomeruli, and we are being asked about what possible symptoms that we will be looking into this patient. We are going to answer as much answers that we can, So options here are your tiredness. B, we have swelling around the eyes, or in some this could refer to the periorbital edema, right around the eyes, puffiness around the eyes. Or is it blood clots traveling through the vessels? Letter D, urine with a dark cola-like appearance. Letter E, high blood pressure. And F, presence of protein in the urine. And then H, is it H or G rather, elevated levels of lipids in the blood. Again, is it tiredness, swelling around the eyes? Is it blood clots traveling through the vessels? Is it urine with a dark cola-like appearance, or high blood pressure, presence of protein in the urine, or elevated lipids in the blood? Now pay close attention. We are talking about the inflammation of the glomeruli. Acute inflammation. Okay? I want you to think ahead. So what are the symptoms of this patient? All right, let's go through the options here. What about letter A? Tiredness. This is a common report, a common complaint by the patient when they come into the hospital, or let's say if they're going to see the doctor. So if you're the nurse seeing this patient for the first time, they're going to complain about the fatigue. And this is a common manifestation in a patient with the sudden onset of glomerulonephritis. And the reason for that is because of the inflammatory process and also the effects of these inflammatory processes into the body. So tiredness is possibly one of the answers here. What about letter B, swelling around the eyes? Let's take a look. Is that part of it? Yes, possibly, because the periorbital edema, or let's say the swelling around the eyes, these are your classic manifestations of a sudden glomerulonephritis, and this is going to be caused by the fluid retention and the altered kidney function. Okay. Now, let's take a look on letter C, blood clots traveling through the vessels. I want you to recall the concept about the glomerulonephritis. Did we talk about possible clotting in those different classifications that I mentioned about yesterday? No. And so thromboembolism is not a typical manifestation of the glomerulonephritis. It's not, okay? But you will see the thrombosis in the patient with the nephrotic syndrome. We just talked about this about close to an hour ago. And so we are gonna have to eliminate this one. Think again about the pathophysiology. Now, letter D, urine with a dark cola-like appearance. Did we mention about that yesterday? Yes. So, the presence of the cola-colored urine, this is basically what hematuria is all about. There is leaking of the red blood cells into the urine. It will be cloudy, kind of looking, and this is a typical manifestation in acute glomerulonephritis, and this is because of the inflammation and the damage to the glomeruli. And of course, the blood cells, the red blood cells, allowed to leak into the urine. That's why we're going to see that frothy, cola-colored urine. Now let's take a look into, so this is a possible answer, and letter E, high blood pressure. So what is all about that? Well, The high blood pressure is going to accompany acute glomerulonephritis because there is fluid retention, there's also retention of the sodium, and the activation of the renin-angiotensin-aldosterone system because of the RAS. Okay. So this is quite similar with the nephrotic syndrome. There is an activation of the RAS. So there's also some form of high blood pressure. And then let's talk about letter F, presence of protein in the urine. So this is the hallmark feature of the acute glomerulonephritis. Again, because there is increasing permeability of the glomerular filtration barrier, the podocytes, the slit membrane, the glomerular basement membrane are now allowing those proteins to leak out. That is why we have proteinuria in this patient. Okay? Now, we're going to talk about letter G, elevated levels of lipids in the blood, hyperlipidemia. Is it part of the nephrotic syndrome or is it with acute glomerulonephritis? Well, yeah, we did not talk about hyperlipidemia and acute glomerulonephritis. We only talked about this today as a complication, right? And so this is not a characteristic assessment finding in the glomerulonephritis. This is more associated with the nephrotic syndrome. And again, because of the liver's responsible of converting more, synthesizing more lipids, and thus causing the hypertriglyceridemia. Now at this point, we're going to have to focus onto your test taking skill here. So again, you need to be familiar with the different signs and symptoms of the acute glomerulonephritis. Also those fluid overload, edema, kidney dysfunction, hematuria, proteinuria. You need to. It's very important. And also use the process of elimination in order that you can eliminate those distractors, those manifestations that are not typically associated with acute glomerulonephritis. So here we have the blood clots, C, thromboemboli or thromboembolism. It's not present in acute glomerulonephritis. It's only in nephrotic syndrome. So you need to eliminate that. Same thing with the hyperlipidemia in letter G. Eliminate that because we've never talked about that part of the pathophysiology in acute glomerulonephritis. All right. Now, another tip for you is to make sure that you are really capturing the entire context of the test question. Make sure that you are really capturing it well. We are talking about the glomerulonephritis, so you can narrow down the search of those manifestations when you're going to be asked, with, of course, with the options available. Okay. Now let's move on to the next question here. It states, when instructing a client on preventing further occurrences of acute glomerulonephritis, what guidance should the nurse provide? Again, when instructing a client on preventing further occurrences of acute glomerulonephritis, what guidance should the nurse provide? Is it A, limit vigorous physical activity? Or is it B, filter all urine through a strainer? Or is it C, promptly address respiratory infections? Or D, measure urine density daily, or actually measuring the urine specific gravity? Take your pick. All right, time's up. So what you can do when you're reviewing this video later on, what you can do is just stop, and so you can think about the possible answer and then proceed. Now, what is the question here again? We are being asked about what guidance should the nurse provide into the patient that has a possible recurrence of the glomerulonephritis. So, instruction on preventing further occurrences of acute glomerulonephritis. So is it A, limit vigorous physical activity? Well, avoiding the vigorous or strenuous physical activity may help at some degree in reducing the strain on the kidneys, but it is not directly going to address the underlying issue with the glomerulonephritis. It will not. Okay. Now, what about letter B? We are filtering all urine through a strainer. So straining the urine is beneficial for us to make sure we can capture if there is any kidney stone, but we are not talking about kidney stones at this point. We are talking about glomerulonephritis. So it will not prevent the recurrence of glomerulonephritis, so eliminate that one right away. What about promptly address respiratory infections? Seems like it. Well, the reason for that is because with the glomerulonephritis, acute glomerulonephritis, this is something that actually can occur because of a prior streptococcal infection, right? It could be a throat, strep throat, or it could be in a form of a skin streptococcal infection, the impetigo. And so weeks or days before the patient develops glomerulonephritis, usually the patient is known to have these infections to happen before that. And so when you answered promptly address respiratory infections, this is actually a good instruction in order that those recurring infections will be prevented. There is proper treatment with the use of the recommended antibiotics in order to prevent further damage of the kidneys. Now let's take a look at letter D, measure urine-specific gravity. This is an instruction. Well, monitoring the urine-specific gravity really is going to assist in hydration status, but it does not play a role in preventing the glomerulonephritis. It doesn't. Okay? So again, our focus here is to teach our patient regarding what to observe if in case they have been admitted for acute glomerulonephritis. And so make sure that you're teaching them about reporting these type of infections. It could be in a form of a skin infection, or it could be in a form of an upper respiratory infection, like a strep throat, tonsillitis, strep throat, pharyngitis. Those are the same issues that we need to address right away. Now, what we need to do here, our test-taking scale here, is to really recognize the connection between the respiratory infection and also the diagnosis that has been established for this patient, which is acute glomerulonephritis. So your knowledge about the pathophysiology is much needed around this time. Okay. Now we also need to use the process of elimination. So you are gonna disregard those options that are not gonna directly address the problem. Then also we have to focus on those options that will really target preventing, or let's say management of the respiratory infection. All right. Now let's move on to the next question here. The client with a new diagnosis of glomerulonephritis seeks clarification on complete protein foods. And which examples of such foods should the nurse discuss with the client or the spouse? So select all that apply. So what are those food items? Because they're asking for clarification on the complete protein foods. Protein complete, all right? So which of these food items have the complete protein? Is it A, nuts? Is it chicken, eggs? Or is it C, seafood? Or is it D, beans and lentils? Or is it E, soy or soya? Take your pick. All right, your time is up. So let's go into the different options here. Letter A. Well, nuts can have some protein content in there, but they are not considered to have complete protein in it. It's lacking those basic amino acids. All right, so we are gonna eliminate nuts. What about chicken, eggs? Well, yeah, Chicken eggs will contain all those essential amino acids that will be helpful in um, doing its bodily processes, and this is going to be one of the best choice for this patient. All right, so we're gonna apply a check mark here. Now, what about seafood or fish? Well, remember, seafood such as fish, it can actually also offer so many amino acids that will be required by the body, and so this is also referred to as one of the complete protein source. We're gonna check. Oh, sorry. We are going to check that as well. And so let's move on to letter D. So what is that? Beans and lentils. So this is going to include those legumes that are rich in protein, but again, they do not provide all the essential amino acids. And so again, they are not classified as complete protein sources. So we are going to get rid of that. Let's take a look at letter E. This can become tricky. What's in E? Well, soybeans or soya, they are going to provide with the essential amino acids. They are also plant-based and also complete protein source. So this is one of the options that we can include in their diet, and that is something that needs to be part of their dietary intake. So we're left up with letter B, chicken eggs, seafoods, and soy. So these are known to have the essential amino acids, while the rest of them, they have protein content, but they lack the essential amino acids. Now we're going to move on to the next question here. So a patient is hospitalized with an early stage diagnosis of chronic renal failure. What should the nurse anticipate finding upon assessment of the patient? Is it A, increased urination, or is it B, excessive thirst, or is it C, decreased urinary output, or is it D, absence of urine output? Pay attention here. We are talking about the chronic renal failure, or known as the CKD. Okay, it's not about the AKI, because the AKI has the different phases, right? We're talking about CKD right now. So what are those manifestations in the early stage of chronic renal failure or CKD? So let's go through the options here. Letter A, increased urination. Well, in the patient with the early stage diagnosis of CRF or CKD, the kidneys will often lose their ability to concentrate the urine. That is the first occurrence. It will lose its ability to concentrate the urine. And so this will now cause the person to pee a whole lot, polyuria, okay? And so they don't have that ability to reabsorb the water this time. So our patient now has polyuria. We're talking about early stage CKD. We're not talking about the diuretic phase of acute kidney injury. That is a totally different disease process. And so possibly letter A is one of the answer, or the answer. Letter B, excessive thirst. What is that? Well, while maybe there is polyuria, the increased thirst or the excessive thirst in the chronic renal failure could happen as well. But the point here is that the primary assessment finding with this patient, especially the kidney, the thirst is only a compensatory mechanism or compensatory response to the increased urination, rather than a direct indicator of the renal function. That is why we are not gonna select excessive thirst, because this is only a compensatory response. Okay, eliminate that one. What about letter C? Decreased urinary output. Again, we are talking about early stage chronic renal failure or CKD. There is a lack of the kidney to concentrate the urine, so they have polyuria. So letter C means oliguria. So that is contradicting. Remove that right away. What about letter D? Absence of urinary output. That is anuria. This is something that can happen into those patients, especially towards the end stage renal disease. And so at this point in the early stage, we are not going to expect the anuria at this point. So we are going to eliminate that one as well. So for the test taking skill here that you need to be doing, we have to again understand the disease progression. You have to understand the different stages, especially in the chronic renal failure. So we're going to start with the polyuria in the early stage, and then followed by the oliguria and anuria. All right. Now another is we're going to have to recognize the primary symptoms that are being presented, and so we are going to target that right away. It said here early stage. So again, increased urination is the hallmark for this disorder. Okay. And again, we're going to have to also eliminate those illogical options when we're going to do the process by elimination. So for those manifestations that are the exact opposites, immediately take them away. Disregard them. Okay. All right. So that is the end of our presentation today. And tomorrow I'll be continuing the discussion in the renal system for the med-surg, and we will be talking about the renal calculi and also some Q&A and nursing management. So I really thank you for your participation today, and I will see you in the next video series.